illumination. So they are called as the illuminators. And for visualization of a particular area, especially in constricted areas such as the nose and ear, we need some instruments for better visualization. So the main thing here in ENT, you need a proper illumination. When illumination should be there for better diagnosis and proper instrument. Even for example, even removing a foreign body is very difficult if you are not having a proper instrument, because if you use a improper instrument, it might cause further damage than the cure. So we'll see what in ENT is the main illuminator which we use for generation together is a Bullseye lamp. The name as such because of a it's the bullseye, that structure of that lamp, you call it as a bullseye lamp. See, this is how it will appear. I further magnified here. See, the bullseye lamp, we use this because you can see a perforation, opening in the center, inside which you have a.
Excuse me, ma'am.
Usually the bulb watts is fixed. 100-watt bulb is used here in however dark the room may be. Yeah. Hello.
Hello, ma'am. Your voice
please?
wasn't clear at all, ma'am. It was cracking in between, actually. So sorry to interrupt you.
From which slide?
From the one next one, ma'am. From Bullseye.
Bullseye lamp. Okay.
Yeah, the next one, ma'am.
Yeah. Now is it clear, no?
Yeah, it's clear now, ma'am.
Yeah. Okay. The bullseye lamp, it gives, this is the one which we commonly used in our government hospitals and everything. This is the one which is preferred also. I magnified in the next slide. This is one preferred because it gives proper illumination and visualization for us. Okay. See, this one, elongated one, you have a perforation or opening in the center, will be of about 100 watts bulb. That is usually preferred. And that light passes through a biconvex lens. And that lens, which has a 30 to 40 centimeters, which you have a focal. And this lamp is usually placed behind the left shoulder of the patient. Okay. It should not be placed on the right side, only behind the left shoulder of the left shoulder or the left ear of the patient, probably around 30 centimeters, because that should not, the patient should not push over the light and excess that focal length of the light which reflects into your head mirror, which I will discuss in the next slide. It should not interrupt with them. So usually it is kept at around 30 centimeters behind the left ear of the patient, you remember, and the focal length is also 30 centimeters, 30 to 40 centimeters. This is a bullseye lamp we use, and then that light which comes from that lamp get focused into the head mirror, which is attached to the plastic band. Okay, this band will be worn by the examiner, because you can use both the hands for examination. For if you use one hand for visualization of the ear, the other hand you can use for removing a foreign body or the wax. So this head mirror plays a very important role. Like both your hands are free. And there are also specifications for this mirror. See, in that one bullseye lamp, that was a biconvex mirror, whereas it is in this case you use a concave mirror, which has a diameter around 9 centimeters and the central aperture is 2 centimeters. So what happens when the parallel rays from the bullseye lamp, it comes and impinges on this concave mirror, which is the round mirror which is attached to the plastic rim headband. You will see like this, the reflection from the bullseye lamp reflected to the head mirror, and then it is reflected over the patient and you can visualize. See, nicely you can see the examiner uses both the hands freely for his diagnostic as well as therapeutic purposes. So you have to, this is the first requisite before examining any patient. And you also note one point, see, the examiner and the patient, they are sitting at a comfortable 1 arm distance, right? So that better, you like how you stand in a prayer and all, no, 1 arm distance. So comfortably seated, and you are at the level, you adjust the stool so that the examiner and the patient are at the same level. If you are examining a child, you should not examine alone the small child. So you have to ask either the mother or the father to hold the child in a proper position, so that you usually what happens while examining the children, instead of diagnosing, they shake and also because more damage. So we have to make sure that we do not cause harm to the child. Okay. Nowadays, this head mirror is replaced by the fiber optic headlight. But what I usually prefer is only that Bullseye lamp. This is one more advantage. You can use it for an endoscopic procedures. It is portable and all that. Of course, the latest advances, you have their more advantages also. Okay. Then this is the general illumination I've told you. And now you have to ear, nose and throat. So all these portions are only you're going to examining in ENT. So we'll start with the throat. Okay. For throat, what do you usually expect? You have to ask the patient to open the mouth and visualize what are there. We are not dentists. So we are going to see the other structures apart from we are not going to concentrate in the tilt. Other structures. So we can see the other oral and oropharyngeal structures. The oropharyngeal structures, you will not get a better visualization. So you use this L-shaped lag tongue depressor. This depressor is helpful for, as the name indicates, depress the tongue so that the oropharyngeal structures are better visualized. Okay. See, while taking the class itself, I will deal with all the instruments simultaneously. So I've already told you Bullseye lamp, head mirror I've told you. The third one, I'm covering the lax tongue depressor. So you need not have a instrument lesson separately. Extra instruments, you can, few instruments alone, you can see through the KKR in the book in the last few pages. So this is a lax tongue depressor. So what do you do with that? You have to depress the tongue and you can visualize the structures in the oral cavity and the oropharynx. Why I put this chart? Before this, we'll go on to the previous slide. See, this is the oral cavity and the oropharynx. See, further magnification, you can see the uvula is the one which hangs in the center. I know you would have all read through anatomy and you'd be thorough with it. But because we're dealing with this, while examining the patient, you will get confusion. So trace the uvula to the tongue. So that area is called the palatoglossal arch. From the behind the uvula, you get a fold and you trace it to the pharynx. That is a palatopharyngeal arch. So from the hard palate, that the soft hard palate continues as a soft palate, and then that hangs in the center as uvula. No? From the palate, the folds occurs. So trace the palate, soft palate to the glossal. It is a palatoglossal arch and the palatopharyngeal arch behind. In between them is a palatine tonsil. So that is why I put this figure. See, now you can see this in this next one. See, you can see the palatoglossal arch, and in between the palatoglossal and palatopharyngeal arch, you can see the palatine tonsils. So this is one which you should know in examining an ENT patient. Normally, the tongue will hide the better visualization of the tonsils. So we use this lag tongue depressor to do it. See, one thing you have to note that while using the depressor, even us, we will get that gag reflex. So we should not put pressure on the posterior one, the third of the tongue. Always the pressure should be restricted, or just a slight pressure only you have to give on the anterior aspect of the tongue. Okay, only for visualization. If you go posteriorly, the patient will develop gag. Okay, next. So we have seen one lag tongue depressor to visualize the oral cavity and oropharynx. Then there are other structures in the pharynx. We have to see them, no? So you use this indirect laryngeal mirror. You can see that this is a long metal rod, metal what is that, stick with attached to the mirror. Okay, it is straight only. Okay, and there is a mirror. Why do you call as a indirect laryngeal mirror? Because see, indirectly we can visualize the structures which are not visible to our naked eye. The reflection of the pharyngeal structures and the larynx will be seen in the mirror, and you can see it with when we see through the oral cavity. Okay, for this you cannot examine the patient like that. You have to anesthetize the oral cavity. You need not give local anesthesia. You can use a 4% xylocaine spray, and you can anesthetize the oropharynx because it is highly sensitive and gag reflex will be there. One, the gag reflex will be there. The other thing is that it will not solve the purpose. You cannot visualize what is a pathology. So it's an easier method. If you anesthetize, local anesthetize it with using a spray, 4% xylocaine spray, then 10 to 15 minutes it will be local anesthetized. Then you can you can catch hold of the left hand, or using any one hand you can catch hold of the tongue in one hand, and using the mirror in the other hand you can gently retract, go behind and tilt, so that you get a better visualization of the pharyngeal and the laryngeal structures. For this, before you doing this procedure, one caution you have to see. You should, any cold objects will produce a vagal reflex stimulation. So before doing this procedure, you have to, one is a gag, one is a reflex will be there. The other thing, there will be fogging of the glass by our own breath from the trachea or larynx. So in order to prevent that, this laryngeal mirror, you have to either with the help of a flame, that is what is that, the cigarette, that is flame you have, no, with the help of that you can heat it, or you can put it immerse this in a bowl of hot water, so that the metal and the glass become warm. And before examining this oral cavity, you have to keep the back side of the mirror in your hand and check whether it is in the body temperature, because it might cause burn injury. So once you have checked that, you can examine and you'll have a very clear image of the larynx and the inferior pharynx. Okay. See, the lip-like uppermost structure is epiglottis, and from that you both have the vocal cords, the white structures, and it goes attached to the arytenoids and the laryngeal fold here, and behind that you have the esophagus. See, when you ask the patient to say that sort of a sound which produce sound from the larynx, you can see the vocal cord movement. The white know whether the vocal cord is paralysis, mass, and all with the help of a simple expertise, and it's very easy. It is non-interventional. You can easily, in the OP procedure itself, you can find a growth or the paralysis of the vocal cord. You need not subject the patient to any procedures. Okay. So this one I just put you another slide. Okay. Now, having some knowledge about what all you will see and what instruments you will use for examining the oral cavity, then we'll move on to the nose. It's a rough idea. I'm just giving it. Okay. So nose, any person, if you come, what do we have to, madam, I have sinusitis, sir, I have sinus. They won't know what is the sinus or where it is and all. So even the headache, cluster headache, they may say it. So see, we should have a better knowledge where the sinuses are. See, you have the sinuses in the front, above the eyebrows, and the middle you have the frontal sinuses, and the root of the nose. You see multiple small sinuses on either side on the cheek. You have the maxillary sinuses, all drain either into the anterior part of the vestibule nose. And the sphenoid sinus, of course, it is present. It's not in this figure. It opens behind the ethmoidal sinuses. You will find it when you see the anatomy in the skull. You can see, because the proper area, all the secretions which are present in the anterior aspect of the nose or through the posterior aspect. So you have to just know about that. Then before saying any, what do you see from the nose in a patient? Everybody has a nose. So what do I say? Sir, the skin is like this. Now, what generally anything you have to say, you have to look for the shape of the nose, because in any rhinophyma and all that, or the tumors and all, the shape will be altered. The other thing, the nose stands in a straight line because of the septum which is there in the beneath the skin, okay, in the center. So that gives shapes and beauty to the nose. Okay, you have to look at the shape, any deformities, any scars, discharging, redness, and all, rhinorrhea, offensive disorder, which we will see in detail when I talk about the nasal examination. So just rough idea about, see, the central mode is a normal nose first figure. You have the central nasal septum, and it's a curved one, bend the nasal deviation nasal septum. So that is what clinically they will call as a DNS, deviated nasal septum. For that we use the SMRs, that is mucosal nasal resection. So that is one thing you just have to remember. Next, just an idea about what are they talking about, the turbinates, middle meatus, superior meatus, all you will have, they'll be talking, but we will know where it is. See, another thing, sphenoid sinus, see in this figure it is seen, the left uppermost, you see the sphenoid, location of the sphenoid sinus. It's better visualized here. Okay, this slide I have mainly put to, it's a cross section of the lateral nasal cavity. See, 3 elevation, pinkish elevations you see. So the elevated areas are called as the turbinates or the concha. Concha is nothing but a bony elevation. Okay, and the depression below, they are called as a meatus. So the superior turbinate, and beneath then you have the superior meatus. Middle turbinate is the middle elevated area, and beneath that you have the middle meatus, and the inferior turbinate and meatus. And you see in the lowermost above the lip, no, vestibule, that is the cavity of the nose. Another thing you have, see, you follow the inferior turbinate from till the last, you can see the eustachian tube, that's the opening of the eustachian tube there. See, in the next figure, you can see I told you, superior turbinate, the bone beneath is called as a concha. So you can see the superior concha, middle concha, inferior concha. Why do you talk about all these things? Why do you examine all these things? Because the sinus drains only through the meatus. Okay, all these sinuses. So we have to have a knowledge about all these things. Okay. Next, then how do you examine? See, now you know something about what are the structures in the nose. So the nose is a closed structure, right? How do you examine? You use a Tudicum's nasal speculum. See, this is a 4th instrument I'm making use of. First was a last, I will ask the instrument's name. You have to tell. Okay. First was a Bullseye lamp. Then it was a head mirror. Next is a lax tongue depressor. Now I'm coming to the Tudicum's nasal speculum. It is a self-retracting one, not a self-retaining one. Okay. So this is the one which you use for both diagnostic and therapeutic purposes. Okay. So there's a method how we hold it. That is very important. Okay. You just hang it with the index finger. I'll show you. One second. This is how you have to hold it. With the index finger, just hang it like this. They'll ask you when you're in the examination, how will you hold it? See, you see, and you also should know that the blades are there. The lower 2 blades, no, they are facing away from you, and it is facing the patient. So you have to hold it in the index finger, suspended like this, with the blades facing the patient. So you have to close it with the middle finger and the index finger for retraction, and that will give a proper visualization of the nasal structures. When you take the instruments and use it for examining the patient only, you will have a correct knowledge about how you use it. Okay. There are small blades and the long blades also. Okay. Now, see, there I've told you one mirror, Sinclair, the what is it? Indirect laryngeal mirror that is used for the examination of the larynx and the lower pharynx. I told you, no. Now, for the nasal, posterior, anterior nasal with the help of the what speculum I told you, Tudicum's nasal speculum, you can examine. But you need to examine the structures which are behind. That is a posterior inferior nasal cavity, no. For that, you use a St. Clair Thompson's post nasal mirror. See, it has both the mirrors are same handle and mirror and all, but the architecture is different. See, this is curved. It's bent in such a way so that it goes behind the posterior soft palate, and you visualize the posterior nasal cavity. Okay, this is called St. Clair Thompson's post nasal mirror. So that procedure is called as a posterior rhinoscopy. This procedure is the same. You have to anesthetize with a 4% xylocaine spray, and you can see. See, this is a handle with a mirror. This mirror shows the reflection. See, the central is receptive and the 3 turbinates are there. From the reverse order, first you see, they will ask you, first you see when you indirect laryngeal mirror, first you see from the lower inferior, then the middle turbinate, then only the superior turbinate. Okay. This is a higher magnification. See, the soft palate of the uvula is there, nasal septum, the inferior turbinate, middle turbinate, and the superior turbinate. You will, when you get expertise with this procedures, very simple actually. You will see all these structures. They will ask what all you will see that. You can also see the polyps, any nasal mass, nasopharyngeal angiofibroma. Everything you can see with this. See, if you tilt the mirror a little bit above, you can see the uppermost adenoids. See, adenoids are there. This will be visualized in the postnasal mirror. I have seen. And if you tilt a little bit laterally, I told you the eustachian tubes open just behind and posterior to the inferior turbinate. Now you can see the eustachian tube open. This is how it's an endoscopic view. Okay, how when you put on now the latest advancement, you can visualize everything with an endoscope. This is how you will see. See, I just put this picture to just know there's an inferior, that elevated areas are the turbinates and the middle one is the septum. If we go further, you can see the nasopharynx. So we will deal in detail when we deal with the nasal examination. So it's another picture. I told you that what all structures you can see. You can see the jelly-like grape-like structures between the septum and the turbinate, that is a polyp. So all these structures you can see in anterior examination of the nasal nose. And this picture I have told you, see, it's only this arrow mark are the eustachian tube openings. Okay, you follow the inferior turbinate. IT is to the inferior turbinate. Now behind that and posterior opening of the inferior turbinate. This is the picture you will see actually. If you have a proper training, you can see this in the indirect laryngeal mirror itself. But you can. This is the one taken from the endoscopic view. Okay, now today we will start having a rough knowledge about an idea about all the how to approach and what all structures you will see basically in detail. A patient comes to you with a problem in the ear, so what all we should see, so that we will deal with it today. So in the meanwhile, can somebody give feedback whether I'm audible and my voice is legible or it's breaking? Please, someone.
Yes, ma'am. Good afternoon, ma'am.
Okay,
Your voice is audible, ma'am.
okay. Shall we continue?
Yes, ma'am.
Okay, now see, just a rough idea of all the what instruments you use, how you use. Now so far we've dealt how you make the patient sit and examine. You should not examine anyone in a standing position. So how you should do, you should use a what ventilation, the illuminated room instruments, what area you have to. Even the patient say there's symptom in some other area, you have to examine all that ear, nose and throat, because as far as ENT is concerned, there is one terminology called as whether it's a localized or a referred pain. Even if it's a pain or any other thing, the pathology may be somewhere, but the patient will be complaining or see, for example, there may be a tonsil in that child, but the child will frequently say, I have paining ears and draining ears and all. So the main pathology is in the oral cavity, tonsil. So the patient, she has developed ASOM and eustachian catarrh and ASOM, and because of that she's complaining of the pain. So we should not just go by the patient. We should ask the history and examine all the things. So today, so that's why I've told about all these given a basic idea about the ear, nose and the throat. Okay, now today we will go the examination of the ear. So as I told you, the ear, it may have a local symptoms and it may give it may have a systemic symptoms also. So for any organ is a method how you examine. So as I told you, you have to sit comfortably with the child, with the patient and the examiner with one arm distance in a comfortably seated position. And you have, for in the case of ear, what you will see externally how it appears. Okay, visualization I put in the next slide. So first I put this palpation. Okay, this and then we'll go there. So this is how the ear will be. Normally, if you take anyone in your house itself or your friends, can you see your eardrum like that? No one will be able to see. So you have to adopt some mechanism so that the external auditory canal is straightened and you can visualize what is there in the ear canal. So usually we will catch hold of the penna with the help of index finger and thumb and retract it upward and outward laterally. This we do so that the external auditory meatus is totally visible and you can see the tympanic membrane. Okay, and this helps to straighten the external auditory canal, and this is the position of holding the ear for visualization. So you have to look for externally, you have to look for any I'll come to the next, any deformities, any injuries, lacerations, or any infections and all. So then you have to see, palpate and see. What are you see? You have to see for the tenderness. See, what is a tragal? I put first one as a tragal tenderness. All of you palpate and see. See in the ear, the front portion, you see a triangular elevated area. Anyone tell me? Are you able to feel that area? Please, someone. Hereafter, I need interaction so that I make sure that I make myself clear. One by one, or admin, whoever it is, who's coming forward now? One of you, please.
Ma'am, yes, ma'am.
Who's this? May I know who am I talking to?
Good afternoon, ma'am. Aditya Narayan.
Aditya. Okay, Aditya, just keep your hand in front of the ear, and are you able to see an elevated area in the anterior aspect? See, there's an ear canal. In front of the ear canal, it is an elevated area. Are you able to see?
Yes,
palpated? That is called as a tragus. Yes, okay. So if you press it and if you feel pain, that is called tragal tenderness. Okay.
Yes, ma'am.
Okay. Now, somebody else, please come back. Somebody, please opt to answer me.
Good afternoon, ma'am.
Okay. Now, see, now the external, may I know who's this?
Ma'am, I'm Aprajita.
Aprajita. Okay.
Yes.
Now you put your little index, little finger inside the external auditory meatus. Use one of your
ma'am.
And
Yes.
the front is the tragus, and behind the main one is the flabby one is the auricle, right?
Yes,
Yeah.
ma'am.
Okay.
Yes,
now behind that there is a depression, and you can feel the depression there.
Yes,
okay.
ma'am.
This auricle, and you can feel a bone behind the depression. Are you able to?
Yes, ma'am.
That is the mastoid area. Just palpate and see. It takes a triangular shape, right? If you find, are you able to do it? There's a
Yes, ma'am.
bone structure.
Yes, ma'am. The
So that
triangle
is the
shape.
that is the master. See, because I'm not able to see you, I'm not able to demonstrate in the video. So I have to have this sort of an interaction so that I make myself clear. Okay.
Yes, ma'am.
Now,
Sure.
this, if you have pain in this area, you have to give a little pressure. If there is pressure, if today they have taken CSOM, no, so discharging here, that patient, if you where do the discharges come from? The small air sacs in the mastoid. What matters a mastoid? This area I told you, no, that is a bone, mastoid bone, which has a small, because of this organism. What is the causative organisms from outside, and they discharge, they need some, the bone cannot discharge outside, no, it has a recess through of draining, okay, through the into the middle ear and then drain to the external auditory canal. So any infection or inflammation will produce, I told you, it's a sign of tenderness will be there, no, it's in the inflammation chapter. So if you sense tenderness in that area, it shows there is mastoiditis. Okay. Aparajita, is it clear?
Yes, ma'am. Yes,
Okay,
ma'am.
then
It's clear.
the
Thank
Fissler
you.
test, we'll move on to the next. Okay, next. Okay, thank you. Next, next the nowadays, first, what a patient should tell, if the patient tells you something, ma'am, I have problem in the right ear, it's severely paining. Okay, what should you do? First, examine the good ear. Okay, why should you know that? Whether that ear also is normal, you have to know. And the thing is that if you examine the bad ear, they suppose there is pus, you introduce the same otoscope into the good ear, that organism will infect the other ear also. So you have, for comparison in the patient itself, suppose there is deformity in by birth itself also, we can find out. So you have to examine the good ear and then go back to the other ear. Now, because we are dealing with this ear examination, we nowadays use a otoscope. So this is another instrument, okay, otoscope. It's a battery operated one, and we use for examination of the ear. So see, in this picture, you can see how it is there. It has an handle. Before going to this picture, this is how we can visualize the structures. See, this is a otoscope. There's a what's a tail or the handle which holds the battery inside, and the head is a has a magnified lens, and there is a bulb also for illumination. So the structures which you see in the tympanic membrane or internal auditory canal or whatever it is, external auditory canals, that is magnified and helps us to visualize. See, this is how the examiner will visualize the structures. Okay. So with this, we go on to the symptoms. Okay. Any person who comes to the ear problem, they will call either have a pain, okay, or that is otalgia. Otorrhea is a discharge, and tinnitus is the ringing sound. Vertigo is the, you know, that either the self, you have a movement, or either the self or the surroundings, your sensation of movement, and the other common is a deafness. So all these 5 symptoms are the ones which are common. So any symptom they say, you have to first ask you where is, or you have to start when it was originated, when did it start, and how long duration, how long it has been, and how the progress, whether it started a little discharge and it has been excess pain, for example, started slowly and now it is aggravated, and like that. Severity, whether it's low intensity or severe one. And you have to anything, not only otorrhea, not only pain, you have to, for anything you, and all these headings you have to ask whether it is unilateral or both ears, intermittent or continuous, whether there is any aggravating factors. Sometimes, you know, this loss of pharyngeal neuralgia, you know, while eating and all, the pain will get aggravated. So there are certain things, when you come to encounter the patient, you will have a knowledge about that. Now, otorrhea we'll take, and what are the first heading? We'll start with the otorrhea. Otorrhea may occur because of many causes, but we will deal under 2 headings: external middle pathology and the other things. Okay. It may occur because of the fungal infections, or that is a fungal infections, that is automycosis. Furunculosis is a bacterial infection. Wax, meningitis is a viral infection of the tympanic membrane or inflammation inflammation of a tympanic membrane. We call it as a terminology, meningitis, otitis externa, tumors of external auditory canal. And middle ear pathology, today as they've taken you, ASOM is acute suppurative otitis media, CSOM is chronic suppurative otitis media. And any tumors, syphilitic tuberculosis otitis media. And there's another terminology which is called as a CSF otorrhea. See, CSF otorrhea is very important thing which usually we miss. And I'll just, because there are the other things, TM, joint abscess and all that. CSF rhinorrhea, you have to see, where is somebody please come on to the line. Who's volunteering this time, please?
Ma'am,
May I know your
Shweta, ma'am.
Shweta, see, to the root of the nose, you keep your hand.
Yes, ma'am.
Okay, where the eyebrows meet and the nose meet, right? Okay.
Yes, ma'am.
There you just between the two medial canthus of the eye, in the center aspect, below the ticca, where you keep the ticca, just below it. Okay.
Yes, ma'am.
There you just think on either side you of that nose, root of the nose. I told you small ethmoidal sinuses are all there, right? And
Yes, ma'am.
you go a little bit deeper and into the, just imagine a bone, an imaginary line. You'll find a thin strip of bone that separates the cranial cavity from the ethmoidal sinuses. So a small that is where the CSF leak appears, starts. Okay, just
Yes,
imagine.
ma'am.
You're able to assume no.
Yes, ma'am.
Imagine somebody is using a endoscope. Endoscope is the one where you put into the nose and you clear, right?
Yes,
No?
ma'am.
Okay. Just imagine you take a tool, forceps, to clear the ethmoidal polyp. Okay.
Yes,
So
ma'am.
ethmoidal polyp, you go to the area of the ethmoidal sinuses. Okay. And you remove the polyps, right? Okay.
Okay,
Now
ma'am.
you give a little more pressure. And it's like a paper, right? All those small cavities are like paper balls. Just a little more cavity, it gets broken. Suddenly, all of a sudden, you get water discharge. Okay. That,
Yes, ma'am.
how will you determine whether it is a CSF fluid or the other fluid? A patient
Ma'am,
after,
sudden headache or decrease in intracranial pressure.
yeah, okay. That may cause a headache. Very good. Next, a patient, you have discharged him. And what will you find? Oh, this is very good answer. Then it will not stop
Sorry,
at all.
ma'am, I don't get you. Okay, ma'am.
It will be keeping on coming. It because the fluid is being on secreting. No, first is headache. I told you. You got done good, very good. And that fluid you have to analyze. CSF fluid, the nature of the fluid, the sample, and the cursive.
Yes,
If
ma'am.
you see it's of the coloration different. It will be given in your book. You go to the textbook and see. It's very interesting. Okay.
Yes, ma'am.
So the CSF rhinorrhea, some people, because I've seen post-operatively, many people will come. Sir, and all that. Just told you this because interesting. When you go to the chapters, madam, now the other discharge, you go to the types of discharge. I told you what all you should see. So the types of discharge may be watery, serous, mucoid, purulent. Purulent is the one you just remember, had the headaches because any inflammation, you just watery. First one is the CSF rhinorrhea because I've already told you, and the safe zone acute, not suppurative one, secretory otitis media, and fungal infection also you will get a watery discharge only. So when you think of watery discharge, all these points should come to your mind. Serious one, the viral infections and safe CSOM you can have. Then mucoid secretions, where all you have to think is like when there are secretory glands areas. For example, only in CSOM where the middle ear is a place where you get the secretory glands. So in that, any infection will be there, you get the mucoid secretions. Okay, the secretions will be produced there and it will be passed through the external artery meatus. Okay, and because it will not be there in the external artery canal. Then the purulent, anything purulent means associated bacterial infection you have to think of. Malodorous. So this is very important because these patient in here, they will present with the cholesteatomas or granulomas. This one is a superadded infection. Anything you will have this malodor. the other thing is a cholesteatoma. Why do you get this bad breath, smell is that because in cholesteatoma, the bones get eroded. Okay. So that gives to a typical smell. So when you get experienced in the OP, when you keep on seeing the patient, when the smell itself, sir will say, oh, this is a patient of cholesteatoma. You have to rule out by taking the mastoid X-ray and confirm it. Okay. Next is a brain blood stain. So that is called serous sanguinis, and you can see it in granulation because granular tissue is the one which is rich in blood vessels. Small blood vessels will be there. So there will be blood stain discharge, carcinomas, as you know, and malignant otitis externa. This is an exam question for you. Usually you will see in the case of diabetes mellitus. Please underline it and make it a point. You read this CSF rhinorrhea, cholesteatoma, and malignant otitis externa. Well, I go across the topic, I'll just give you some thing also. Then the other one, I told you that is the serous sanguinis or blood stained one. And then you can even get frank blood. Frank blood means there's something when trauma that you will get frank blood. The other is a glomus tumor. It's a vascular tumor or any vascular malformation, you can get it. Okay. This is about the discharge, types of discharge from the ear. Then moving on to the other symptom of the ear. First we finish the discharge. Then is a tinnitus. Okay. Okay. What is a tinnitus? Tinnitus is a noise within the ear where there is no external sound, but you feel there is something ringing. I can hear some sound. That may be because of the two causes. One is a subjective one, and the other is an objective one. Subjective is that when there local causes also and systemic also. If it's because of the local causes, something will be there. Like inside us, inside the elbow of one is ototoxicity. If you take your Asperger's disease, they become aquestic neuroma. And postoperative is a local that's confined to the organ. Okay. Systemic anemia because of the increased blood supply, and hypertension, diabetes, thyroid disorders, wisdom teeth, and most commonly we see is excitation is anxiety, and depression we usually come across this in OP. Okay. And even in anemics, the tinnitus, we miss it, but we see people recover also. Then the other is the objective causes. What are the other causes outside the organ which can cause this tinnitus? Okay, what can be there? Somebody please come to the line. Who's there? One of you please answer. Please come forward. One of you, Shweta, please.
Good afternoon, ma'am.
Who is this?
Ma'am, Parvati.
Parvati. Parvati, are you able to differentiate between the subjective and the objective causes?
Yes, ma'am.
What is the subjective now? Subject. You are the subject, right?
Yes,
see, you are the subject. So the subject now we are dealing is with the ear. So
yes,
if the pathology is in the ear, that is subjective.
subjective.
Okay. If it arises from the other structures, it is objective. Sure.
Okay.
Clear now?
Yes, ma'am.
Okay. See, this is the first one is impact wax, but that is not inside. That is confined to the ear. It's another outside one which is causing the pathology. Clear now?
Yes, ma'am. Yes, ma'am.
Okay, ma. Next is the foreign body in the ear, secretory, autosclerosis and all. Eustachian tube dysfunction also. You can get it, glomus tumor, vascular bruise. All these things, you just know they produce some sound. And that sound will be heard by that individual in an excessive way. That gives a called as a tinnitus. Okay, am I clear now?
Okay, ma'am.
Okay,
Yes,
we'll move on to the next one. Why does in the conductive class, the deafness, they hear the tinnitus? Somebody tell me. I put it straight away. Masking effect of the environmental sound is lost. Some of you, apart from the one who answered, somebody else answer, please. Quick. Time is running up. One of you, please. Boys, nobody is there. All slept. All are playing PUBG. I don't get any response from any of the boys. Am I boring? Are you all hungry? A few more slides. Somebody answer. No. Am I lost in the connection?
No, no, ma'am. No, ma'am. You. Yes,
Then
ma'am.
why are they not answering? Ah,
I'm not sure,
it's
ma'am.
not a compulsory class, no? Who's this then? Next time and all, I'll ask each. I'll note down the names and call one by one. Okay. See why the conductive horse? Because I'll be learning a lot. Short of time, I'll just hurry up. See, in the conductive loss, that's you don't hear it. Yeah, that's a conductive deafness then. So the sounds which inside them, that will be more. The people will not hear the sound of the fan, whisper voice, and those children playing and all. No excessive loudness, if they use only, they can hear it. So that is why those people with a conductive hearing loss develop tinnitus and respond with the help of hearing aids. Okay. Then moving on to the other, finishing the local examination, local symptoms of any person who comes with a ear problem, we have to look for them. We have to intracranial extension, headache, fever, chills, neck rigidity, nausea, vomiting, everything has intellection. Headache, you have to rule whether there is any complication of sinusitis, any sigmoid sinus thrombosis has a complication of the sinusitis, headache, fever, chills and all will be there. Neck also, because meningitis can develop because of the complication of sinusitis. Intracranial pressure will increase and might cause a nausea, vomiting and all those things. So this general symptoms are also very essential while examining the local symptoms. Okay. Then you have to ask for the past history, recurrent upper respiratory tract infection. The upper respiratory tract infection we have to ask, and also in the cleft palate. Somebody please come up. I need one of answer, please, immediately.
Ma'am, yes, ma'am.
Who are not playing PUBG, please answer.
Good afternoon, ma'am.
Who's this?
Aditya, ma'am.
You answered previously also, no? No,
Yes.
first time.
Yes.
Huh? No, none of the other guys are there. They just on it and went away.
I don't know.
You don't know. Huh?
Good afternoon, ma'am.
Who's this then? May I know who's that?
Ma'am, Sai Abhijit, ma'am.
Okay. Why didn't you all answer me?
Ma'am, I just fixed my mic. It wasn't working on the headphones, so I had to disconnect.
This is the same answer my child also tells to the teacher on the online class. Okay,
No,
I
ma'am.
believe it.
I've just fixed the mic. That's why, ma'am.
Okay.
Sorry, ma'am.
It doesn't matter. Just tell me why cleft palate you have to ask in the case of a ear. Because I have to keep on talking to the mobile. I don't see you guys also. So just tell me why cleft palate. Just tell me why cleft palate you have to examine for the ear. Why do you look for the cleft palate? Is it related in any way?
Is it due to possible ear infections because it provides a pathway for infecting organisms?
Yeah. Actually, recurrent upper respiratory tract infections occur in these people because it's an open one, the mouth and the ears, everything like, eustachian tube and all, everything is, you will not get that fold, which gives that gripness for the, what is that? Canal stiffness and all. So anything frequent respiratory, upper respiratory tract infections will be there. So the ear discharge will.
Yes, ma'am.
Okay, good. Okay, then we have to ask for ear probing, swimming and all. Then family history of otosclerosis. Does family history? Okay, what is otosclerosis? You tell yes or no. That is enough. So that yes. Does it play?
Yes, ma'am.
Yeah.
Yes, ma'am.
Yes, of course. It plays a part. And today you guys are going to read what is otosclerosis. Okay. And whether it is common in females or it's genetically you get it. So only we specifically ask about the family history. Okay. So it's very interesting one, and you have to, when read the otosclerosis, you have to read what operation is performed to, what medication you do, and what surgical procedure you do in the case of otosclerosis. Okay. Then of course, poor living conditions and hypertension and all that. So coming to the local examination of the year, somebody else apart from you, please, somebody who's here, please come up fast. I'm coming to the end of the session. One of you come
Yes, ma'am.
forward. Okay, may I know who's this?
Aishwarya, ma'am.
Aishwarya. Which is the pre-auricular area, Aishwarya? I told you to palpate the tragus, right?
Yes, ma'am. In front of the tragus.
Yeah, the tragus, in front of the tragus, that is the pre-auricular area. Okay.
Yes,
You have to look for the sinuses. Why do you look for the sinus in that area, ma?
Because, ma'am.
Whether it's wrong or right doesn't matter. See, while tell me.
Ma'am, because there's increased chance of infection.
No, not like that. Okay, that occurs because of infection only. I agree with that. See, while across the line of development of the face, no, from the embryo, see that arches and all, you have that pre-auricular. If the tract does not get closed properly, that sinus tract will be there. That will get secondary infected. So if you go back to the embryology and see, for anything, if you go back, you have to study from the anatomy and embryology so that you don't forget it. Okay. So the remnant of that sinus tract will lead to the infection that will cause the tract. Okay. And fistula also. Then scar, swelling and all. And what common swelling you can expect in the pre-auricular area, ma?
Not sure, ma'am.
Lymph node. You have to know for lymph node enlargement is there.
Okay.
Okay. Well, next, having examined the post-auricular area is behind the auricle, right? You itself answered. Okay. Will you answer me? You have to look for, I told you, any sign of inflammation. You have the warmth, the tenderness, pus is there, or anything, all the change in color, elevation. And another one common people, like from childhood, we can see, when the ear it is lifted up, maybe it is this, அப்படின்னு சொல்லுவாங்க. What is that?
Ma'am, is it because of abscess formation?
இல்லடா இந்த parotid gland சொல்லுவாங்கல்ல அம்மா அம்மா
I'm sorry, ma'am, you're cracking.
The earlobe is elevated. The earlobe is elevated, lifted means the parotid gland, no inflammation, it will take large. It elevates the movement. Okay.
Oh, okay, ma'am.
So lifted earlobe, you have to. So if you suspect a parotid enlargement or the mumps, what do you do? Will you see something in the oral cavity? Come, parotid gland in the oral cavity.
Yes, ma'am.
It is a gland, no?
Yes, ma'am.
Secretion should be drained.
Secretion
so you have to see for the redness of the opening of the parotid gland. Okay, yes, inside. Where do you expect the opening? In the buccal cavity inside. Where do you expect the opening?
Behind the second molar area.
Yeah. This is the one where you use the lax tongue depressor and you have to visualize it. Okay, good. Yes. So post-auricular. Then post-auricular is another place. This is they will usually ask in the exam, McEwen's triangle. Somebody told you palpate the mastoid antrum. So that in the triangular area, see, that is formed by the boundaries of suprameatal crest above, the posterior margin external artery canal, and the tangential line joining those two. Okay, I need one of the boys coming because I'm going to finish the session fast. One of the boys, please volunteer quickly.
Yes, ma'am.
Who's this?
Sai Abhijit, ma'am.
Okay, Sai. See, you put your hand in the external artery, little finger in the external artery meatus.
Yes, ma'am.
Put one thumb in the behind in the mastoid area.
Yes, ma'am.
Okay, now the one external artery meatus, no, uppermost border, just trace behind. That will be a superior meatal that line. Okay, where the uppermost border.
Yes, ma'am.
Okay. And and that imaginary triangle I'm asking you to form. Okay, posterior aspect of the external artery canal, you draw one line, and the tangential line drawing these two, connecting these two, you will find a triangle as shown in the figure, the red color dotted ones.
Yes, ma'am. Got it,
That
ma'am.
is an equivalence triangle where you see for the mastoid tenderness, and you approach that for mastoid surgery, we have to go through that only. Okay.
Yes, ma'am.
Okay, next
Thank you,
topic,
ma'am.
we go on to the anomalies. Yeah, thanks, Pa. Congenital anomalies of the pinna, you will see whether how it is developed, whether one auricle like that or not. You have to see. This is how it will appear, the lobe ear, back ear, and all that. And having finished, we'll go on to the external artery canal. What you will see, somebody who's there, wax, stenosed canal, foreign body, sagging, neoplasms, and all, you can get it. Okay, next, after finishing external, what typically you can see is in the tympanic membrane. I need one person to answer me. Am I audible? Please.
Yes, ma'am.
Yes, ma'am.
Who's this? Who's this? One volunteer, new volunteer. Please,
Aditya
please,
Narayan, ma'am.
Aditya, okay, you are only interested. Okay, fine, Aditya. This is a right ear or a left ear? Quick, I need this interaction because I cannot be talking to the mobile.
Left ear, ma'am.
Yaar? Right or left?
Right ear.
Right ear, ma'am.
Ear.
Right
Who's
ear, ma'am.
saying right? Okay, left is somebody told me.
Ma'am, me, ma'am. Left.
Right or left? If you left, no problem. I'll help you to tell you what is right or left.
Towards the right, ma'am. So right ear, ma'am.
Left
Okay,
ear.
where does the handle of malleus point? Huh? No, this is a right ear. See, always the cone of light right, that is anterior inferior quadrant, the reflection will be there. Okay, this is a right ear.
Oh,
See,
yes,
always you have to look for the, because you will not find in some cases the cone of light, because in a dull membrane and all. Then how will you find out whether it's right ear or left ear? You have to look for the handle of the malleus. But in all cases, in perforation and all, we won't be able to draw it. That will also be eroded. Okay, the handle of the malleus will be pointed backwards, and along with that, that area, elevated area, is called as the umbo. See, examine, you just imagine, open up the umbrella, pa. When the umbrella open on it will be just rounded, no? So that tympanic membrane is lifted up. That elevated area is called as the umbo. When your headlight goes and goes and reflects on the tympanic membrane, that gets reflected as an anterior inferior aspect like a cone. So that is the cone of light. If you see the cone of light, that is a normal TM, right?
Yes,
Okay. Okay. Somebody else, please come forward. Where is the past tensa? Where is the past flaccida?
Ma'am, past tensa is in the posterior inferior quadrant. And
Okay.
past flaccida should be superior, ma'am.
Kana, who's there? Who's this?
Sai Abhijit, ma'am.
Sai. See, Sai. See, this tympanic membrane is the round one. You're seeing the figure, right?
Yes, ma'am.
That one outermost, you're seeing it is written, right? Annulus and annulus.
Yes,
okay, this entire area, this covered, this is a past flaccida. Okay, because it is flaccid. Okay.
Yes.
Then you follow the umbo and the handle of malleus, that line.
Yes,
above this pinkish area, no, that only is past flaccida. The other is sorry, this lower one is a past tensa, and the upper one, that area, pinkish area above the handle of malleus, it is a past flaccida. Okay.
Yes, ma'am.
This past tensa is thickened in the periphery to form this annulus. Okay.
Yes, ma'am.
Any perforation in this area of the past tensa, it is a safe suppurative arteritis media, safe here. Okay. Am I clear?
Yes, ma'am.
Okay. This past flaccida, which is above this rim annulus, any perforation there is an unsafe here.
Ma'am, any perforation above the?
In this area, in the past flaccida.
Flaccida. Okay. Yes, ma'am.
Apart from this past tensa.
Yes, ma'am.
It's unsafe here. And along with that, if there is marginal perforation. Why marginal perforation? Because it will involve the bone. The annulus and the bone also is eroded. Okay?
Yes, ma'am. Yes.
Those all will converge, and the unsafe here. Okay?
Yes, ma'am.
Okay, how many membranes, how many layers are there in the tympanic membrane? 1, 2, 3. Somebody fast, quick. It's a rapid fire round. Fast.
3 layers.
3. What is the outermost layer? Come on.
Epidermal layer.
Yeah, sure. Middle.
Middle fibrous.
Yeah, sure. Inner.
Mucosal.
Mucosal. Why is the mucosal? The middle ear cavity, you get the mucosal membrane lining. So it is a continuation of the lining forms the innermost layer. Am I clear?
Yes, ma'am.
Why is the outermost layer epidermal? Why? Fast.
It's exposed to
Because
the
it faces
external
away.
Continuation
environment.
of external
It
auditory
is
canal.
a continuation of the lining of the external auditory canal. It comes and goes as a continuation layer. So middle one is a fibrous one. Okay. So that is why when you get a perforation for the first time, because all these layers, it will heal, provided it is properly intervened. And again, if it goes, it will not heal. Okay. Now, so far as given a knowledge, we'll move on. So you have to, for into tympanic membrane, we have to know whether there is the anatomy, whether it is a moving, and how do you view the movement of the tympanic membrane. Is it movable? Mobile? Somebody tell me. Is it mobile?
Yes, ma'am.
Yes.
Why is it mobile? Why should it be mobile?
Air pressure changes
Air
in the
pressure.
middle ear.
It should move or it should vibrate so that the sounds are transmitted to the internal canal only because we are able to perceive the sounds because of the vibration. Okay, in the drums, you just put your fingers and drum it. The vibration are only transmitted as sound. So similarly, the external ear has to go and get impacted in this drum like a drums. So that will be transmitted to the 3 ossicles in the middle ear. What are 3 ossicles?
Malleus,
And states, and they transmit it to the cochlea, and the cochlear nerve, it goes into the brain. Okay, so this you have to know, and this movement can be visualized with the help of a Siegel's pneumatic speculum. There's another instrument I've told you today. Okay, Siegel's speculum is like the otoscope, and with the bulb where you can, like a BP apparatus, you can increase the pressure. Okay. Nowadays, it is attached to the otoscope itself. Okay. Then when you see the tympanic membrane, you have to look for the congestion, granulation, perforations, polyps, cholesteatoma, air bubbles, retraction pockets and all. Okay. What is the time? Am I crossing to? Time, please.
It's
2:10,
ma'am.
2:10. You are going for the next class?
Yes, ma'am.
Okay.
2:30
Right.
minutes.
What?
The next class will be in the same link. So the next class
Next
will be in the
class?
same link, ma'am. So we have to wind up the session
Okay.
before.
Right. That's what I will.
Next class will
Okay.
be in
Then.
the same link, ma'am.
Okay, right. Now, till tympanic membrane, I have a few more slides, but I cannot continue now because of you. This one, because it's a clinical examination, part 1, part 2, part 3, I'll make this in some other day, okay, when we are all both are comfortable. Because I can rush it off, but it will not be solve the purpose. Okay. So far, was I clear to you all?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
If anyway you find, because I have totally lost clinical touch, I'm in a non-clinical side. So if you want me to improve in some aspect and make it better, just let me know so that next session we will put it in a way you want it. Okay? Did it solve the purpose?
Yes, ma'am.
Yes, ma'am.
Okay, thank you, children, for being so attentive. We can continue in the next session. Okay, as
Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much.
Thank you, ma'am.
Bye. Somebody remember the slide, pa? The tympanic membrane slide. Who's this coordinator? I don't remember. Jagan.
Ma'am, I'll do.
Please,
Jana,
mark the slide from where we
Yes, ma'am,
have
sure.
stopped. Please, the slide number.
Okay, ma'am. Sure, ma'am.
Thank you.
Thank you, ma'am.
Yeah. I should exit, leave, no?
Yes, ma'am. Leave will help you get out of this conversation, ma'am.
Okay. Thank you so much, pa.
Thank you so much, ma'am.